Welcome, Derek. Derek will talk about sepsis in 2024 and what's new, what's next. Looking forward to your talk.
Thank you, Michael. Thank you, Nee. Sorry for being a little late. It was great listening to John's talk, and I don't know who should have gone first. I think we're maybe both setting up the other. So I'm going to start by telling you that after spending hours yesterday talking about machine learning models, phenotyping, individual treatment effects, and platform trials, I just couldn't face doing it again. So yes, in sepsis in 2024 and in 2025, we're going to keep on talking about phenotyping. And actually, there's some great talks on these talks in this session. So I'm not going to talk about these at all. I'm going to instead say a couple of other things. So in terms of just taking the task literally about what's happening for sepsis in 2024, I was thinking about what new information will we get? Do we know that we will get? And there are a couple of trials that have now finished that should come out. And there's many trials coming out, but I just gave these two examples. Bling3 will, I think, be presented in Belfast in about 2 months. And that is actually just asking the question of whether you should give beta-lactams intermittently or by continuous bolus. So it's a sort of old question, but our Australian colleagues have just completed a huge trial and that result coming out. At the same time, there's a trial coming out from the UK that's very interesting that is taking pneumococcal vaccine and giving pneumococcal vaccine to patients in the ICU with sepsis to see whether that's going to boost their immune recovery and therefore influence their post-ICU, post-sepsis trajectory. So anyway, I was just trying to think literally about what concrete pieces of data will we actually get in 2024, and this is a couple of examples. But what I'm going to do in this talk, however, is ask us to step back for a moment. And I want to start by saying, every time you're asked to give what's the future, we don't spend that much time saying, what have we already done from the past? And I keep on thinking about, for example, I remember when the Surviving Sepsis announcement was made back in, I think, 2024, the goal was to do a 25% reduction in mortality worldwide in sepsis. And everyone thought, yeah, I know you need to say that, but who's actually going to do that? And I was thinking, we're not very good at declaring success. And so one way about thinking about how you go into the future is to, first of all, work out what can you stop worrying about to clear space and make room for new ideas. Otherwise, you keep adding things, and we only have so much room in our brains, and funding agencies only have so many dollars to hand out. And so sometimes it might be good to say, you know what, don't give us any more money to study this problem, because it's largely done, so we can truly focus on some new problems. So I think we have solved some things. So I'm going to say that the front end of emergency or critical care works pretty well for sepsis. I think patients are now rapidly identified, resuscitated, and started on IV antibiotics. Not everywhere, and there's still a big implementation science agenda in this space, but I don't know that the future of sepsis needs to be about still working more and more on what you do first when the patient gets into the ICU. I do think there's still questions about what to do literally in the first hour. Like, we all give 30 cc's per kilo and then randomize the patient. And the question of whether we should give 30 cc's is an interesting one, but it's almost impossible to think of the study design for that, because you almost have to give the fluids to prove they have septic shock before you can go and get consent. And so working out what the study design looks like is a bit tricky. And I think far fewer patients consequently die quick hypotensive deaths. And I'm going to say these as sweeping statements. So you're totally allowed to nickel and dime me on not being nuanced enough. But broadly, I think this has been a big improvement over the last 15, 20 years. I would also say in the 21st century, ARDS is pretty well solved. Again, feel free to start throwing tomatoes at me. But other than COVID, in this century, I can barely think of a patient that I've seen that died a hypoxic death from ARDS. So patients with ARDS die in our ICUs, but I don't think they're dying of ARDS. I think that's largely a problem that we created, and then we got on top of it with better resuscitation, with avoiding over-ventilating the patients and so forth. And the reason I'm bringing these up is because if we don't declare victory, we're going to spend an inordinate amount of energy on the front end of critical illness. If I look at the weekly update that comes into my email inbox from Critical Care Medicine or the American Journal of Respiratory and Critical Care Medicine, I sometimes think we're still fighting the battles of the 80s. Like when you see all the papers that are being published, it's like we're still doing stuff that seems really old-fashioned, and meanwhile, we're not putting enough energy into a couple of big problems. Oh, the other thing I would say, I'm not going to talk about it too much, but I also think, where's nosocomial sepsis gone? You know, back in the 70s or the 80s, it was a huge portion. In fact, agencies like the CDC used to think that sepsis was basically nosocomial sepsis. No one talked about community-acquired sepsis, but community-acquired sepsis is basically overwhelmingly what we're dealing with today. So let's shift our energy to two far bigger problems. Problem number one. Problem number one is we look under the lamppost. We study sepsis when the sepsis patient gets to us. But most sepsis is community-acquired sepsis, and hospitals are not the community. The sepsis begins days before the patient gets to the hospital. There's a potential to massively reduce morbidity with early detection and intervention before they even get to the hospitalization. Now, if you're an intensivist, you might not care about this, but if you're a sepsis researcher, you should go where the problem is. So just because my clinical practice might be in the ICU, as a sepsis researcher, I should be going to the root of the problem. Now that feels impossible. There's no healthcare professionals around, there's no data collection. Sorting out early sepsis from mild infection will surely be incredibly difficult. And I want to put it to you, it's no more challenging than it was in a number of cancers. In the United States now, it is normal that everyone come 50 years of age is going to get an endoscopy to start looking for the risk for bowel cancer. That is unimaginable 25 years ago. The whole idea that the entire country would have a gastroenterologist giving them an endoscopy, like, are you shitting me? Pardon my French. But that's like an incredible lift. Similarly, that whole idea that every woman would get a mammogram and then get them every few years. I mean, these things seemed unimaginable. But once they realized that they had to lift that kind of public health effort in order to get ahead of cancer, then what was unimaginable becomes imaginable. So it is important to start thinking about how do we actually get to the front end of sepsis. We have to start moving out of the hospital. We could begin with high-risk cohorts where the possibility of closer monitoring is possible. So patients who are being discharged from the hospital with a high likelihood of readmission, or nursing home patients and so forth. And of course, the exploding world of wearables allows us to think about monitoring even in places where we couldn't previously have monitored. And there are even people now trying to think about smartphone and wearable monitoring specifically for sepsis far away from the hospital. The other thing is it true that there are no healthcare professionals involved? This paper from Vinnie Liu and Hallie showed that actually a lot of patients before they show up to the ED have actually encountered someone in the healthcare system in the prior few days. They did go to see someone. It turns out that if you were feeling crap for a few days, sometimes you called your GP or you called someone. And of course, it's very hard to sort out, is this just mild flu from day one of what in 5 days will be septic shock? And so I'm not saying this is easy, but this is why we need to declare victory on some of the other problems so that we can actually turn our attention to this problem. All right. We also are engaging in all these public awareness campaigns, but I don't really know what we're telling people because we're not generating any data on the pre-hospital space. And so we just end up telling people in these public, like the 6 Signs initiative in the United Kingdom, it's sort of very vague. And there's very little empiric research going on to generate more focused information to tell people. And then I want to say that in COVID, at the start of COVID, it was totally seen as a hospital-based illness. And yet over the space of 18 months, we really moved forward to give the public more and more of a role. Such that at the beginning, it was a little bit of public awareness and education, maybe put a mask on, maybe stay at home. And at the end now, we're almost going to have self-diagnosis. You certainly self-test. No one goes to a clinic to test themselves. They do it at home, and then they'll soon be able to get their Paxlovid just sent right to the house. So you can totally change the mindset on an acute illness and move it out into the community. All right, so that was problem 1. Problem 2 is hospital-based, so we can all breathe a sigh of relief if we all work in the hospitals. Thank God he's stopped talking about all this community-based stuff. I went into intensive care because I hate the outpatient clinic enough already. Okay. Problem 2, let's start with the clinical vignette. 55-year-old woman presents to the ED in septic shock, fever, high white count, profound hypotension, elevated lactate, altered mental status. For 5 days, she was feeling like crap, but no one did anything about it, but that was my first problem. So what do? We give them IV fluids and pressors, intubate the patient, send off cultures, lab work, chest x-ray, shows pneumonia, by the way, start IV antibiotics and transfer to the ICU. Following morning, so imagine she came in on the Sunday afternoon, it was a terrible night. It's now Monday morning, seeing her on Monday morning. She's now on low-dose vasopressors, but she's warm, she's well perfused. Blood pressure is back. You're weaning down the Levophed. White count and procalcitonin are elevated, but actually they're already better than day 1. Came in with a white count of 30, it's now down to 20, and so on. And requires 50% FiO2 and 7.5 of PEEP, which is much better than last night. Last night, it was awful, up to 80, 90%, dialing up PEEP, thinking, oh my God, but then they got through it. Following morning, it's fine. There are just a couple of picky problems. She's comatose, she has ILIS, and she has acute kidney injury. Who cares? Okay. Clinical course, over the next 2 days, the cultures confirmed strep pneumoniae, sensitive to antibiotics, the oxygen requirements improved quickly, white counts continuing to normalize, and they've weaned off vasopressors. So actually, you knew this was going to happen. And so on the Monday morning, after rounds, you went to the waiting room, and there was the very concerned husband, and you said, oh my gosh, thank goodness your wife came here, because last night was really rough. She was really, really sick. But you know what? She's out of the immediate danger, but she's still critically ill. She'll stay in the ICU, and we're just going to keep her here. And say, oh, so what are you doing for her now, doctor? Well, we're just going to sit and wait. Oh, okay. Yes, that's what you need. Tincture of time. Okay. And so, sure enough, you were right. Can't be extubated for 10 days, altered mental status and delirium for almost 2 weeks, doesn't make urine until a month out, and eventually discharged after 5 weeks, but requires extensive rehab. 6 months later, isn't back to work, suffers ongoing fatigue, weakness, and depression. Okay. Is this just like a 1 in a million case? How common is this case? So using the same data that we use for the Seneca phenotyping that you've seen here, we just looked at all patients admitted to UPMC with sepsis who were really sick, patients who got a SOFA score of 8 in the first 24 hours. So this is very sick patients. And we looked pre-COVID. So we were looking, and we had 12,000 patients over a 2.5-year period. That's one admission to our system of one of these patients every 2 hours. 25% hospital mortality rate and a higher 90-day mortality rate, obviously. So this is the vasopressor duration. The mean duration is less than 2 days. These are in patients who were having SOFA scores of at least 8. So these are sick patients, but we only gave vasopressors for 2 days. The lactate was down to under 2 by day 2, and day 1 was sometimes only 4 hours long. Day 1 was midnight on the first day. So look how quickly the shock goes away. This is just like the patient I told you about. Ventilation is only about 1 or 2 days longer than the duration of vasopressors. We actually got them off the ventilator very quickly. And again, this wasn't all-comer sepsis. These were the sepsis patients with really high SOFA scores. But neurologic function, altered mental status, look at that. They've got a GCS of 10 going on for out to 2 weeks. And then there's that other organ, what's it called, the kidney? It's not doing well either. So why does end organ dysfunction persist? The perfusion is restored, macroperfusion is intact, and when we've done studies of macroperfusion, especially we can tell it's pretty reasonable. Innate immune disturbances are no worse than before the patient was admitted to the hospital. The IL-6 level on the Monday morning is lower than it was on the Saturday when the patient was not yet in shock, feeling terrible, but totally mentating and still making urine. Didn't have ileus, a little bit off their food. There was a ton of innate immune response going on while they were at home, and yet now they're in ileus, comatose, and not making urine. There's very little evidence of cell death, very little necrosis in adult sepsis, a small amount of renal apoptosis, macroscopic appearances of major parenchymal beds, all look largely intact, all except for one organ. The lung totally gets trashed. But you all went to medical school. You learned about, this is gray and red hepatization of the lung. Mammalian species, with and without antibiotics, have been getting pneumonia for millennia. And as long as you survive the initial insult, the lung just completely comes back. There are, however, odd behaviors. Enterocytes seem capable of still making tight junction proteins, but they no longer send them up to the tight junction. And so then you get gut leak. And the cell is making it, but it's just not sending the proteins Z01 and all the rest of it, occludins. They're like sitting in the cytoplasm and they're not going to do their normal job. So it's like they're on strike. And what's interesting is new enterocytes are doing that. Your enterocytes are born every 72 hours. The enterocyte's born on Wednesday of that week, when there's no hypertension, lactate's normal, gut perfusion is fine, brand new enterocyte. First thing the enterocyte does is say, yeah, I'm not going to work properly. I'm not going to maintain my tight junction. I'm alive, I'm fine. I'm just not keen on going to work. All right. So we have this ventilation and vasopressor I showed you before. This is the hospital length of stay. So the patient remains bedbound for weeks despite rapid resolution of the initial insult. So what is this red stuff? What is this red stuff, and how can we shrink or eradicate it? I want to give you an analogy of the London Blitz. Septic shock is like an air raid over London during the Blitz. The attacking bombers are microbial invasion. The civilian population represents the organ parenchyma responsible for homeostasis. The firefighters, the ground-to-air artillery, they represent the host defense mechanisms. And the cleanup crews represent repair, healing, and fibrosis mechanisms. When the air raid strikes, the civilian population stops working in the factories, stops teaching in the schools, stops selling food in the shops, and rushes underground. The firefighters, the artillery, barrage soldiers, and so on, they mount a defense. And then after the air raid, the cleanup begins, and everyone comes out of the subway shelters and immediately goes back to work. Immediately. Following night, there's another raid, they all go down again. Then as soon as the alarm clears, they come back up and they go back to work. A few people get blown up. But the people that don't get blown up say that was a shitty night, and then they go back to work. In sepsis, after the air raid is over, the organ parenchyma remain hunkered down in the shelter. The alarm is out, and someone shouts down to the shelter and says, okay, you can come up now. Say, no, we like sitting down in the subway. It's like you told everyone to go home from work. They turned on Netflix, and then you said, you can now come back to work. You say, no, I'm enjoying watching my show. I'm no longer going to come back and do the work that I was going. That's what all our organs are doing in the ICU. Why? So this is an old idea. Over 20 years ago, we wanted to shrink the organ dysfunction burden and try to move this down. And then we would drop ICU and hospital use, we would decrease iatrogenesis, we might boost long-term recovery. But 20 years later, there remained no therapy to enhance recovery of any parenchymal function in sepsis-induced multisystem organ failure. So in other words, we can fix the immediate threats to life, shock, severe hypoxia in 2 days, then we simply wait with our fingers crossed. Meanwhile, all of the patient's parts look to be well tended, but we can't accelerate the end of ileus, we can't accelerate the end of coma or delirium, we can't accelerate the end of acute kidney injury, we can't accelerate the end of ICU-acquired weakness, etc. So the mission for 2024 and beyond ought to be articulate why seemingly intact parenchymal systems don't resume normal function after the threat is gone. Review existing avenues of research pertinent to these questions by organ, by theory or concept. Consider what the on switches would be. Give me a bag of wake-up juice. I'm looking for the wake up and go home juice, to hang a bag of that, to something to accelerate recovery. And review deficits in our current knowledge and methodology. And I'll give you a starting point. We don't have a single animal model routinely used that recreates these modern ICU states. We have all these sepsis CLP models, which is asking whether a caveman could survive sepsis. We don't do any causal inference in animal models of the Monday morning. Once the shock is fixed, but the animal is comatose and not making urine, what can we now do mechanistically to fix it? And again, it's because it's not in our mindset. We're still solving problems from the 80s and 90s. So, some ideas about what trips up recovery from sepsis. Sepsis might start as an immune disorder, but in later stages, immune function or dysfunction may just be an epiphenomenon. It could be another end organ. We keep thinking this is all the immune system. I'm just putting it out there. Maybe it's got nothing to do with the immune system. There are patients with HIV walking around with no coma, no delirium, no AKI, and no ileus, with a much worse immune system than anything you see in a sepsis patient. Sepsis might just be badly orchestrated hibernation. As a species, we forgot how to hibernate. But when we get a shock that would normally have killed us prior to the birth of intensive care, maybe we rush around to turn off all the light switches, to quickly hibernate, the way some of our teleologic ancestors did. And now we've turned everything off, and then it's in the dark. And then they say, okay, it's time to wake up. And they say, wait a minute, where's the on switch? And we've not actually preserved the function for getting out of hibernation. Maybe delayed recovery is an extreme example of sickness behavior. Ruslan Medsetov's lab is studying how animals move around in groups after CLP and how they engage in sickness behavior. And maybe this wanting to crawl off into a corner and die is being driven by some endocrine function that we need to sort of coach people out of their sickness behavior. It could also just be complete neural rewiring. Who knows? Okay, so in summary, sepsis, like every field, is hoping to benefit from AI, machine learning, molecular phenotyping, and platform trials. It's not just sepsis. But more specific to sepsis, it might be good to reflect on progress. I think we've made incredible progress with early identification and resuscitation and reduction in nosocomial sources, and turn to two big nasty problems: reaching patients before they need to be resuscitated and fixing patients after they have been resuscitated. And with that, thanks very much.